Good afternoon, good evening. Thank you so much for joining us for the Mpox special briefing from Africa CDC. My name is Margaret Edwin, the Director of Communications. I will be moderating this session. Today, we are joined by Dr. Ngashi Ngongo, the head of the Incident Management Support Team based in DRC. And I will now hand it over to him to start the session. Over to you, Dr. Ngashi.
Yeah, thank you very much, Director. Good morning, good afternoon, colleagues, depending on which part of the world you are in. I would like also to welcome all of you to today's press briefing, and just start by giving apologies from the DG, who really wanted to be with us today but couldn't because of another very important meeting that is taking place right now. We have more than about 36 ministers of health that are gathered with him, talking about the ministerial leadership agenda on the sidelines of the AU Assembly. I think that's the reason why he couldn't join us today. But the entire team is connected, both from here, Addis, and also from Kinshasa, to just give you an update of where we stand right now with the Mpox outbreak. Now, with those, Director, if you can get the slides. Yes, we'd like to give our usual multi-country Mpox and other health emergencies update in Africa. Next slide. Today, we'll talk about Mpox. We'll also briefly talk about Ebola in Uganda. We'll touch on Marburg in Tanzania, and we'll say a few words around about cholera in Angola. Now, the key updates are that now we have one more country, that is South Sudan, that reported its first confirmed case of Mpox clade 1 last week. Now, that it is a case with a history of travel to one of the neighboring countries, just that shows that we still have a lot of work to do with point of entry surveillance. And in 2025, we have now reached 16,291 cases that have been notified, of which 4,203 confirmed and 143 deaths among suspected cases and 11 deaths among confirmed cases. They are to say that out of the 22 countries, 13 countries that reported cases that are still in active phase. But the good news is that we have 9 of the 22 countries that have already moved into the control phase. Now, for AP week 5 of this year, we have 2,560 cases that were notified, of which 726 were confirmed and 41 deaths among suspected cases. Now, if we compare with week 4, we see that there's a decline on the number of cases notified. There's also a decline on the number of cases confirmed, but there is a rise on the number of deaths among suspected cases. Another important information to say is the distribution of vaccines, that on the 7th of February, Rwanda received 5,800 vaccines that were delivered, and the DRC received another 200,000 vaccines. Now, on Ebola in Uganda, there are 9 cases that have been confirmed since the declaration of the Ebola outbreak in Uganda. And also important to say that we have started also seeing some disruption in the delivery of services resulting for the pause of the US government funds, because this is a question that we asked even last time if we had seen already some of the implications. Now that has started to surface now. And finally, just to say that there's no new confirmed cases of Marburg from Tanzania since the last report that we gave. But if you look at the AP curves on the right, just let's go back. you'll notice that over the last 3 weeks, the first graph shows the confirmed cases. You see that there is a steady decline. If you also look at the second graph, the one on the bottom with notified cases, you also see that there is also a decline. Just to say that we are observing that, but we have some caution in interpreting that, given also the context in which we have with the insecurity that happened in the Eastern DRC, and what we are just saying now about the pause of US funds that has started also to show some impact in the countries. Next. Now, when we look at the progression then of Mpox on the continent, starting from January 2024, we can say that between January 2024 and February 2025, we have now a cumulative number of 97,785 cases that have been notified, of which 22,390 confirmed and 1,735 deaths. And the number of member states has now increased to 22. Next. Now, looking at the incidence of confirmed cases in countries with active phase, I think we mentioned about 13 countries. What we see is that in general, we have Uganda and DRC, where we have the highest numbers of cases reported that are still on the upward trend. In general, when we compare the last 6 weeks, that is from the last week of 2024 to the fifth AP week of 2025, and comparing with the 6 weeks before that, we say that the trend is still upward in Uganda and DRC, but at the same time, we are seeing some good trend in Burundi, where we have observed a reduction of about 51%. Just to say that it is the beginning of some good progression in some of the high burden countries. Next. Now let's look at the situation in the DRC. In total, 71,704 cases that have been notified, 15,539 confirmed, 1,443 deaths with a case fatality rate on notified cases of 2%. But when you look at the week 5 that we are reporting today, the cases notified were 2,178. That is compared with 2,052 on week 4. That shows a slight increase. On confirmed cases, we have 404 in week 5 compared with 481. That shows a decline. On the number of deaths, we have 2 cases confirmed among the confirmed cases. That is a case fatality of 0.5%. And again, the same picture that we've been seeing in DRC, lower case fatality among confirmed cases, high case fatality among suspected cases. And the number of reporting provinces out of the 26 are 11, which shows that there's a slight improvement from week 4, where we only had 7 provinces that reported. Now, looking at the confirmed cases, the distribution, we have males account for 46.7%, but children now in the DRC, children below 15 years make 49% of all cases. And we have the 2 clades that are co-circulating in at least 4 provinces now, in Kasai, Kinshasa, Mai-Ndombe, and Chopo. And the main highlight is that the testing coverage has gone down. The testing rate is 100%, meaning that all the samples that reach the laboratory are tested. The problem is the proportion of samples among suspected cases validated that reach the laboratory. And the test positivity rate is 42%. Just to say that 42% are Mpox, but the remaining 58% are non-Mpox cases related to other diseases. Next. When you look at the age and sex distribution, what is important is that children below 15 years of age are more affected in endemic provinces where clade 1A is predominant. But in Kinshasa, which is the second graph, in Kinshasa, we see that it is the adults that are the most affected. But remember that in Kinshasa, we have the co-circulation of 1A and 1B. And in the remaining two provinces of North Kivu and Sud Kivu, children below 5 and young adults are the most affected in those two provinces. But just to say that I think we see that children are still making the most affected in endemic provinces. Again, reminding us of the importance to include them in vaccination, which the government is now moving forward with. Next. Now, when you look at the distribution of suspected cases also during week 5, which is the map on your left, you see that we are still getting cases from the east, that is from South Kivu, North Kivu, from the center where we have Sankuru, and then from Chapa and from Equateur as well. But if you look at the second map of confirmed cases, you'll see that testing, the number of confirmed has really reduced in all those, including on the eastern part, in the central part, as well as on the western part. That's the issue that we mentioned, that the pause of the US government funding is now starting to show its result. The US funding through USAID or supporting the sample transportation from the provinces to the main laboratories, because of the freeze, we see that sample transportation has really suffered, as you have seen that the testing coverage has gone down to 29%. But in addition to that, we also have the humanitarian crisis that is also going on in North Kivu in particular, but also Sud Kivu, where the tensions are already being manifested, which also explains, again, the reduction that we can observe in the proportion of those samples that are tested. Next. Also, looking at Uganda then in week 5, cumulatively, all the cases notified have reached now 4,131, of which 2,479 confirmed, with 16 deaths and a case fatality rate of 0.6%. But in week 5, the number of new cases that were reported was 222, which is lower than the 323 reported in week 4. That's a decline. Mortality has remained at 0. And the distribution of cases, males make 56.9% of all confirmed cases. Uganda is still dealing with clade 1B. The testing coverage is one of the best, 100%. The positivity rate is at 60%. And the number of districts that are affected is 83 out of 146. But those that are active that were active in week 5 are 52 districts. Next. In Uganda, we also looked at the distribution of cases by age and sex. And what we see, we try to look at the hotspot district that account for more than 50% of all cases. And the main observations are that persons between 18 and 39 years account for the vast majority of all cases that have been reported in the hotspot district in Uganda, about 80% of them. But also important to mention that males consistently have higher case numbers than female in Uganda, and that Kampala and Wakiso district are the ones that show the highest burden, indicating that it's still predominantly in urban areas where Mpox is circulating. Next. We reported last time that Uganda had received 9,000 doses of Mpox vaccine, 10,000 doses of Mpox vaccine. 9,000 have already been administered. That to say that we've seen the same pattern that we saw in Rwanda and also in DRC and in Central Africa as well, that the acceptance of Mpox vaccine remains high, almost in all the countries. Sex workers were targeted for the first block as the high priority group. And we've also noticed that young adults aged 20 to 49 represented 86% of all the people that were vaccinated, which kind of corresponds to the group of the 18 to 39, where we have more than 80% of cases in Uganda. And that also to say that Uganda has been allocated an additional 100 doses of Mpox vaccines, and the process is ongoing with the documentation being completed for those vaccines to be deployed rapidly. Next. There's a slide before this. Yes, in Burundi. Yes, we also wanted just to report the situation in Burundi, that the total number of cases notified has reached 6,489, of which 3,288 have been confirmed. Burundi has done very well. Only one death reported so far with a case fatality of 0.03%. Now, in week 5, the number of cases notified was 160, a rise from 135 the week before. And the number of confirmed cases reached 71 compared to 52 the week before. The case fatality has remained at 0. But in terms of the distribution by sex and age, males make 52% of all cases, and children below 15, 37%. In Burundi, it is clade 1B that is circulating so far. The testing coverage is among the best, also 99.1% of cases that are sampled and tested, with a test positivity rate of 51%. But they have to say that there are 45 districts already affected, but currently there are 16 that are active. Next. Now, on vaccines, in general, what we wanted to report that we have already deployed 747,780 doses of Mpox vaccines deployed to 6 countries. And of those 6 countries, 5 are currently vaccinating. I think the only country of the 6, it is Liberia, that is also in the process of preparing the launch of the vaccination. Next. Now, let's talk about Marburg in Tanzania. As of February 10th, the situation has remained as reported last week. No new case that has been reported. I think there were 10 cases in total that were reported, and all of them died, with one of the highest case fatality rate of 100%. And all the cases were in Kagera region, which borders Burundi, Rwanda, and Uganda. But we have already been working with the ministries of health in Uganda and in Burundi for preparedness for Marburg. And Rwanda, I think, is still ready, just a few weeks after they declared the end of Marburg in Rwanda. Next. And the situation of Sudan Ebola virus in Uganda, since the declaration of the Ebola outbreak on January 30th, there have been 9 cases that have been confirmed, and 5 among healthcare workers, and 1 case that has passed on with a case fatality at 11%. But all the remaining cases, 8 of them are still admitted and being followed very closely. And the contacts have been identified, and they are also being followed. And there are ecological investigations that are ongoing to also determine the source of the outbreak in Uganda. Next. And finally, wanted to talk about cholera in Angola. Since the last update, I think there were 979 new cases, 25 deaths. That's a case fatality rate of 2.5 that were reported from 9 provinces. Now, in total, that's 2,259 cases, of which 435 confirmed. But the total number of deaths has now reached 75, with an overall case fatality rate of 3.4%. We hope that it is the beginning of the decline of the case fatality rate. In terms of the distribution, males make 54% of all cases. Children below 15 years account for 40% of all cases and 35% of all deaths. But on the response side, I think Angola has already launched the cholera vaccine. I think they have already more than 100,000 people that have been vaccinated, and the rapid response teams have also been deployed. Now, in summary, we can say that we see some significant progress in the Mpox response, but the current insecurity in the Eastern DRC, with the risk of spread of cases in the neighboring countries and in the neighboring provinces within DRC, coupled with the pause of the US funds, increases really the risk of getting the situation out of control. The spread of Mpox to South Sudan is another eye-opener that we really need to strengthen cross-border surveillance, which remains extremely important. But also at the same time, we are working with Sudan already to make sure that we have an aggressive approach right from the beginning to contain the outbreak when we still have fewer cases. The laboratory capacity in DRC in general, we presented to you the decentralization approach. I think we've seen an improvement in terms of the availability of lab testing capacity in the provinces and also in the hotspot health zones. But the challenge comes now with the transportation of samples because of the pause on the US funding. I think that's to say that on the IMST side, we are very much committed to continue the rollout. Let's go back to the previous slide. The decentralization of the laboratory. And we also would like to work with the embassy of the US government to ensure that there's a good understanding of the waivers, I think, that were provided for the life-saving humanitarian response, of which we consider that Mpox should be one of them. Now, there are 5 countries that are conducting vaccination, and we are hoping that more vaccines will be deployed and that countries like DRC will accelerate, and Uganda to help them contain the outbreak. We'll continue working with Uganda on the Ebola response to ensure that they have everything that will take the capacity on the ground, but most importantly, very strong surveillance with active case search and the close follow-up of contact to contain it, with the fewer cases that have been identified so far. But most importantly, also, we'll be working with government to look at ways that we can mitigate the resource gap that have been created by the pause on the US government with alternative funding that include domestic resources already available through the emergency funds of most of these countries. I think with those, I would like to stop there, Director, and open up for comments and questions.
Thank you very much, Dr. Ngashi. Let's take the first 2 questions from the chat group. We have Eva from the German news agency. She asks, how is the Ebola situation in Uganda developing, and is there a potential risk of spillover into DRC? That's the first question. The second question comes from Gilbert, a science journalist from Uganda, I believe. He asks, how is the conflict in Eastern DRC affecting medical research on these diseases, and how is Africa CDC and partners mitigating this? Let's take the first two questions. Over to you, Dr. Ngashi.
Yes, thank you very much, Director. On the first question about Ebola in Uganda, no, as I reported, I think we still have those 9 cases so far. No new case has been reported since the last time that we reported to you. That means that the situation is stable because the identification of contact has been quite aggressive. We have more than 200 contacts that have been identified for just 9 cases, which is good. The 8 cases are all admitted and they are doing well. We are also hoping for a lower case fatality and higher survival. But then the risk into the DRC is real. Is real in the sense that we will expect the movement for now has taken place from DRC into Uganda. But what we hear now that with the stabilization of the situation in Goma, we are also seeing the reverse movement of the population. Now, those that ran away that are also coming back, into DRC. Just to say that, the risk of spillover remains important for the neighboring countries, DRC in particular, that we need to continue really strengthening the cross-border surveillance, which is critical in this situation. Now, on the medical research, I think the situation in Eastern DRC did stop, I think had an impact on the research on the ground as expected because people were running away from the shooting. But with the stabilization of the situation now, we are hoping that everything should go back to normal. For example, the main laboratory in Goma that has been playing a very important role, in research was closed during the early days. But we hear that a few days ago, the laboratory has now reopened, I think, which is good news to then resume with the activities. I think it is a situation that will continue following very closely. Over to you, Director.
Thank you very much. Let's take the next two questions. Paul from the Lancet, you have the floor.
Thank you very much. So my first question has to do with the impact that you shared with us regarding the U.S. government's decision. I would like to know whether there has been an assessment of how exposed African countries are regarding the projects that are directly relied upon. For instance, if transportation of samples, do we know other critical initiatives that are directly affected? Then what is currently the mitigation plan in addressing these issues? If we can take that issue you mentioned, for instance, what has been done to quickly address this? Then what is the approach the Africa CDC is taking in engaging African governments to act? And I have a question on the vaccination trial in Uganda. So do we have an insight regarding the status of the vaccine trial? Thank you very much.
Thank you. Let's take the next one before the response. We have Gabriel Emmanuel from NPR. You have the floor.
Thank you so much. My question was actually really similar to the previous one. I'm interested to hear about the impact. In addition to transportation, what else has been impacted, and what's the plan for how to mitigate it? But I think it's very similar. So thank you.
Thank you. Dr. Ngashi, over to you.
Okay, I'll take the first question, and then I hope Papa is still in Uganda now. I think he's the one leading on the research and the vaccine trials. I don't know if Papa is connected, and yep, perhaps, yeah, I think Papa is connected. You can take the second question on vaccine trials in Uganda. Now, on the first one, we had a very important, I think, meeting over the last 2 days here because we have the opportunity of the AU Summit of Head of State. just to reflect a little bit on what could be the actions of Africa CDC moving forward to help these countries mitigate the impact of the US government decision. Just to remind you that the reason why we are so concerned is simple, that we have 84% of the US global health investment coming to Africa. And we can imagine that there's no doubt that Africa will be the most affected. What we put as a plan for Africa CDC, number one is that we need to share the information, especially information on the waiver, because even what is happening in the DRC now, we got the impression that all the member states are not available, are not informed about the waiver that has been provided for life-saving humanitarian assistance, for which we have the emergency responses like Mpox, Ebola response and Marburg in general. We have antiretrovirals for people that are on treatment currently. All that information hasn't yet gotten clearly to the member state. We will be sharing that information as the immediate first action to encourage them to go and meet for the leadership at country level, the ministers of health, to meet with the US ambassadors and clarify what falls into the waiver to be able to at least maintain these life-saving interventions. Now, that is the first thing. And then the second thing that we also put in our action is to undertake a gap analysis. Try to understand in our member state what are the programs that were affected and the activities that were funded through the US government across the board, whether it is maternal and child health by USAID or emergency responses, HIV, malaria, across the board. We undertake a gap analysis that will then tell us country by country how much money is here to be lost. That is number two. Number three is then to come up with a mitigation plan that will be looking at the resources that could be mobilized locally, starting with the member states themselves. As you know, that most of the member states do have a budget that is actually kept for emergencies that could be mobilized at very short notice, in these circumstances, but also link that to effort beyond domestic resources on some of the other sources that we can also mobilize for them, including innovative financing. Just to say, to respond to your question, is that we haven't yet done it, but it's something that we just discussed over the last two days as the three main actions of Africa CDC with the key partners as we move forward. Now, Papa, if you can come on the question of vaccine trial in Uganda.
Thank you very much, Dr. Ngashi. There were already existing in country 2,160 doses of the recombinant VSV vaccines. So that has been kicked into action with additional 10,000 doses on the way. 214 contacts were identified and 8 rings were also identified. 7 of the rings have been created and the vaccination is proceeding with the contacts. Without going into much detail, the way it's randomized, it is the immediate and delay rings. So the vaccination has proceeded in 7 of the rings and is ongoing. Other partners are involved in deploying monitoring of the vaccines, but the news is that there were pre-existing vaccine, there were pre-existing protocol, so everything got accelerated and the vaccine trial has kicked off.
Thank you very much.
Thank you very much.
Thanks, Papa. Over to you, Director.
Thank you. Let's take the next question from Priyanka from Chemical and Engineering News. You have the floor.
Question, Margaret. I missed a little bit of the audio when you Dr. Ngashi was answering the last question. So I apologize in case I'm repeating anything. But could you, Dr. Ngashi, explain how exactly the pause in U.S. funds is affecting, for instance, the containing the Sudan virus outbreak in Uganda? What specifics are sort of being, what are the holdups there given the pause of the funds? And the second question that I have is, you talked about ecological sort of monitoring or investigation to sort of identify the source of the Sudan virus outbreak. Could you sort of explain a little bit more about what those investigations look like? Thank you.
Thank you. Let's take the next one. Janice from Bloomberg, you have the floor.
Good afternoon. Thanks again. Dr. Nagashi, you said a few weeks ago that some of the funding gaps might be filled by China, Japan, and Korea, as these countries had previously helped with, cash vaccines and other equipment. I was just wondering if you had any detail as to progress on talks with any of those three or any other countries that have not typically been, as involved, but might be able to fill that funding gap. And then my second question was actually very similar to the previous question, but maybe a little different in that I was just wondering with PEPFAR and this very limited waiver, we're seeing certainly on the ground here in South Africa, a lot of the programs kind of being dismantled, even though the core ARVs or etc. are still under the waiver. And I was just wondering, in terms of the broader health security on the continent, in a situation like this, what talks are being had in terms of potentially diverting funds from things that you have been very involved, with focusing on, like Mpox, to ensure that we don't have a resurgence and lose years of effort on the other epidemic of HIV.
Thank you. Dr. Ngashi, over to you.
Okay. Yeah, thank you very much, Priyanka and Janice. Perhaps let me just invite Papa and also, yeah, I think this is something that you were talking about, you were explaining this morning about the way that the US government is affecting the Ebola response in Uganda. If you can just say a few words. I explained already how it is affecting the DRC. I think one of the key areas that have been really hit very hard is the transportation of samples from the hotspot site to the laboratories. They use the USAID funding among the main sources, and with the pause, I think that has been affected. That's why we're saying that we have even seen a decline in the testing rate while we are scaling up the equipment for laboratory capacity. But the fact that the transportation of samples has become a nightmare, also together also with the insecurity in the East, are the two main factors that are contributing in the context of the DRC. My colleagues, I think one is in Uganda right now. Papa, if you can come in, and Yap just returned from Uganda 2 days ago. You can take the question on the same, what we've seen as the impact in Uganda in particular, and also comment on the ecological investigations.
So maybe I will take over the ecological, and Dr. Yap was with us when we had the launch of the Ugandan response plan. The minister spoke on the impact. So in terms of the ecological study, we met with some of the senior researchers, the incident commander for Uganda. The protocol has been developed to look at prospective and retrospective sero survey. Built in that the ecological survey, some of the animal will be captured and sample isolated, specimen isolated for testing. So there's going to be a broad-based retrospective from some of the DHIS to sample to see residual infection that was not picked up, and then active within the zones of the Mpox. There are 10 districts at risk. We try to narrow it down to a few. The protocol is going to get ethical clearance. So we are closely working with Africa CDC and other partners to lead the sero survey and to get some ecologists. We're trying to get some scientists. Africa CDC has been asked to provide these scientists to do the animal spillover events. So eventually we see that happening in the coming weeks, where detailed ecological study will be done and to understand the prevalence, the basal prevalence of antibodies to the infection to see why is this in the community. So it's really ongoing. Over to you, Dr. Yap, on the impact of the low USAID support.
On the issue of how Uganda is affected by the USG pause, it's both on the side of Ebola, on the side of Mpox, but also on HIV and so on. Dr. Ngashi has already talked about the issue of sample transportation, which means that some good number of samples were collected in the district are not managing to reach the laboratory where they are supposed to be run. And this is true for Mpox. For Ebola, I think Uganda is doing a great job in terms of resilience to try to push and ensure that the sample arrive on time, which is great, but there are some few challenges. The other part is the surveillance, on the sense that especially for Mpox, a bit less on Ebola as we do speak, the surveillance rely on epidemiologists and also some community healthcare workers, and some of them, not all, some of them were supported by the US government. So those one will definitely impact the way we can respond, the way we can track the case, especially for Mpox. But as we are looking at it as an integrated response, Mpox and Ebola currently, it will affect both of them. But it's important to highlight that solutions are being found by the government in place, and the partners who are there supporting are doing quite a great job to ensure that we do have all the contact, the sample, and the case that are well managed. Over to you.
Okay, thank you very much. Yep. Now, on Janice's question about funding from China, Korea, and that we mentioned last time, I would like to confirm that we have received the funding already from both China and Korea, I think, which is good news. I think when we reported scores, we had already advanced negotiations and we're just in the process of disbursing the funds to Africa CDC. But for the long term, because we need to find 84% of the money coming to Africa is a lot. For the long term, you might have heard that now the Africa Epidemic Fund, which was already approved by the head of state and then recommended that we work on the framework has also been approved, the operational framework for the Africa Epidemic Fund. That is the good news for us. I think it has taken us 2 years really to negotiate within the EU to get the approval of the Africa Epidemic Fund as the platform that we are going to mobilize funding to be filling the gap, as it has happened in the case that we are talking about. Now, you are also aware that on the 14th, that is tomorrow, with President Kagame, Africa CDC is organizing an event here with head of state on domestic financing for health. We started already thinking about, as you saw, one of the graphs that I showed that indicates that the foreign investment in Africa has been declining over the last 4 years, which means that what we see now is just the continuation of a trend that has been already there. That's why we had already thought about setting up this mechanism and also working on different fronts. One is to push for domestic resources to be increased. As you are all aware, we have the Abuja commitment that has never been honored by the vast majority of the member states. That's why President Kagame is leading now the domestic health financing event tomorrow to get the commitment really of the member states to invest more in health. I think that's one source that we see as generating the funding that will feed the gap. At the same time, we do have ourselves within the EU, the leftover of the COVID fund. The only problem that we had with that we had no mechanism really to use the money. That's one of the things that also motivated the establishment of the Africa Epidemic Fund, so that the leftover can then be put into the epidemic fund to allow us to use the money for the current need. We had gotten already an approval from the Permanent Representative Council to use 10 million. That's one of the initial funding that we started with the Mpox response. But now that we have the AFF taking shape, I think that's another pot of money that we can also, we are planning to also mobilize to support our actions. And finally, the discussions also over the last few days, we're looking at innovative financing, different opportunities that we can also put in place, outside government, looking at the private sector, where we can also mobilize additional funding that will help us fill the gap. I think that's the vision as we move forward. This all the need to really establish a fund that is ready to help, in circumstances like these of life-saving humanitarian assistance is critical. We are looking at, the Africa Epidemic Fund, counting on the domestic financing, counting on the COVID fund, counting on innovative financing as different ways that we can mobilize funding to support the response. I think given the fact that COVID funds are available, we can still tap into that depending on the gap analysis that will be conducted in member states. We'll be able to see what are the urgent needs and what are the sources that we can leverage immediately to fill that gap. Over to you, Director.
Thank you very much. Let's take the next question from Paul. You have the floor. The name is Paula, not Paul. Paula, you have the floor. Paula, can you hear us? All right, let's take one from Genevieve. Genevieve, you have the floor.
Hi, thank you so much for the presentation today.
Genevieve?
Hi, can you hear me?
Yes, we can hear you. Go ahead.
Sorry, thanks so much for the presentation today. From a manufacturer's perspective, has the CDC formalized a demand forecast for the Mpox? And secondly, with regards to the discussion around the funding and how it's going to be sourced, will that be looked at being distributed to the localization for the manufacturing of Mpox on the continent? Thank you.
Thank you very much. Let's take the next one. This one is from Flavia Nasaka of Uganda Radio Network. She asks, what is the latest about the trials happening in Uganda? How many people have been enrolled? And when it comes to therapeutics designed for Ebola Zaire, work for the Sudan strain. So let me go again. So do the therapeutics designed for Ebola Zaire work for the Sudan strain currently? Those are the two questions. Over to you, Dr. Ngashi.
Okay, thank you very much, Director. I'll answer the question on manufacturing, and then I'll ask Papa to come back again on the trials in Uganda. On manufacturing, I think the question is if Africa CDC is creating demand. The response is yes. What we did, first of all, if you look at the continental plan, we did estimate the number of cases that are expected. That's one thing that we did, and made a projection over 6 months. And if you look at what is in the plan and the projection that we have, we're very, very close really to what we have in the plan there. And then based on that, we then quantified the needs of the member state in terms of diagnostics, the need in terms of vaccines, and in terms of IPC. Now, when we talk about manufacturing, now the discussion right now have centered around tech transfer for the manufacturing of vaccines. I think there are some discussions that are already advanced with some of the manufacturers that we can't really disclose here. On the diagnostics, we have already we have established a committee, a diagnostics validation committee with experts in Africa that review different research and especially the performance of the different tests, and then make a recommendation on those that we can use. we have the needs of the countries. I think we have been also buying together with WHO most of the tests. I think that we have been reporting here that on the diagnostics, it's us actually the main buyers, together with diagnostics. Now, the therapeutic is the one that is we are still at the clinical trial level. I think that's what Papa Musoka just reported last time. We are working with Panther to push the clinical trial because tecovirimat that was used in clade 2 during the 2022 outbreak in Europe was tested in clade 1 and was found not efficacious. I think that's the reason why we've gone back now to the drawing board. We are still at clinical trial level. We have no product in the market for now that we can use for therapeutics. Now, Papa, over to you on the clinical trial.
So for the therapeutic trial in Uganda, all 8 of the confirmed cases, as you will know, the index case died, but all 8 of the confirmed cases are ongoing remdesivir under the WHO Mori protocol. The country has some initial remdesivir that was used. If you go back a few years ago in the PALM trial in the DRC, remdesivir was not too effective with Ebola Zaire, but all of the recommendation from the expert group shows that there are promises with the remdesivir for the Ebola Sudan. So with the protocol, we'll be able to get more information, but all of the confirmed cases are currently receiving remdesivir. Thank you very much.
Thank you very much. Let's take the next 2 questions. Baby Musamba from East Africa Radio, you have the floor. Musamba, if you can hear us. All right, let's take one from Paula. Paula, if you can hear us. Okay, I don't seem to get a response there. Let's take a few others from the chat group. We have one that asks, how do you look at the situation of transborder surveillance between Sudan and other neighboring countries and the role of the Sudan government to treat the situation within the ongoing conflict? That's one question. And then the other one would be on the conflict in the Eastern DRC and how, hold on. So let me go again. So this question is about the ongoing Africa Union heads of state summit in Addis. If Africa CDC can comment on any public health issues that might come up in the discussion. Over to you, Dr. Ngashi.
Yes, thank you very much, Director. I think we had already yesterday, we had the Committee of Head of State meeting of Africa CDC that was chaired by the President of Comoros, where the DG gave an update on the situation of public health on the continent. I think that was already done yesterday. And the procedure is that the committee will also brief the assembly just to make sure that the head of state are up to date with the major trends of public health on the continent. I think the first part, which is the critical one, took place yesterday because the head of state are organized in different committees. The president of the Committee of Head of State of Africa CDC, which is our third governance body, would then prepare a briefing. I think that would be passed to the assembly. In addition to that, there are also different opportunities that are being created. I think there will be an event on immunization that will also invite the head of state. There's an event that I spoke tomorrow about health financing. with the head of state again under the leadership of President Kagame. And right now, as we sit here, we have the meeting with 36 ministers of health and 9 ministers as a representative, about 45 or 46 countries that are gathered right here in the Sheraton where we are right now. We also discuss again key public health issues on the continent. I think that is ongoing. In addition to that, there are also some recommendations on the support that come from the head of state for the work of Africa CDC, different recommendations that they make to support our resource mobilization, to support our autonomy, the different areas that are important to make our work easy. That is ongoing. And then there was a question about the trans-border surveillance. Is it what you are saying? No, it is true that that has become is a major challenge for South Sudan and also a priority. As you see that the case itself is a case that had history of travel to one of the neighboring countries. It tells you already that the surveillance, trans-border surveillance is very weak. That's the way that they've gotten into that case. And definitely it's also a priority, of the IMST support to South Sudan, knowing that because of what has happened in that country, the system is one of the weakest really on the continent because of all the years of conflict and so on that have reduced investment in the health system, but even destroyed, I think, some of the the system, the infrastructure that has been constructed. I think it just tells the fragility that is South Sudan is and the priority really for our action. But also saying that another thing is also the fact that even in the region, you have Sudan has got a border with DRC. It's also one of the weakest borders. Also the action that need to be taken on both sides, not only Sudan, but all the neighboring countries, especially those that are among the hotspot countries. We need to continue our effort to strengthen cross-border on that side as well. And then there was a question on conflict in the Eastern DRC. I think this is a major threat. The most important is that we have discussed a strategy to ensure the continuity of services, both Mpox services and also basic primary healthcare services. And the partners are mobilized. And one of the good things is that now the partnership will expand to include humanitarian agencies that are working in those contexts also to collaborate with us to ensure the delivery of vaccination, IPC, surveillance, collection of samples for laboratory, but also ensure the basics of maternal and child health services that need to be continued. There's a strategy that was actually requested by the Minister of Health himself, who wanted the partners to support that strategy, and we are part of the design of the strategy and also the support for the implementation of it. Over to you, Director.
Thank you very much, Dr. Ngashi. And with that, we have come to the end of the weekly briefing this week. I will hand it over back to Dr. Ngashi for his closing remarks. Over to you.
Yes, thank you very much, Director. Let me really thank all the participants for really making the time to attend this weekly press conference. We very much appreciate the interest that you have on Mpox, the interest that you have on the continent, as a whole. And as I always say, these conversations where the questions that you are asking are also your contribution even to the design and the response. I think all those ideas are things that we capitalize on and also integrate in our response. We can see from the data that we are starting to see some good trends. In countries like Burundi, we can say confidently that, yeah, I think the situation is now improving. that there is a decline that has been now sustained over a couple of weeks. We see the general trend. Also, that is also, although we have what we can call cautious optimism, but it is a sign that perhaps in the coming weeks, we might see a reversal. We are also just concerned about the insecurity, hoping that that can also come down to allow us to continue with the response. And we count really on all of you. I think all the effort that each one of you can really contribute, either on really pushing for to resolving the situation in the Eastern Congo, or also on resource mobilization, on just sharing the information about this outbreak and the impact that it is having. I think all those are contributions that are most welcome. I think for us, once again, thanks to everyone, and we look forward to receiving you next week on the same day at the same time for the next press conference. Thank you.